Is it recording, Jay?
Yes, ma'am. Action.
We can start now. All right, so brain tumors. We're not going to spend a lot of time on brain tumors. There's a lot of definitions in brain tumors, so do go back and look at your definitions. But when we are talking specifically about brain tumors, primary tumors originate in the central nervous system. So that means in the brain or in the spinal cord, you can have a primary brain tumor. Secondary tumors are those that metastasize from other areas of the body. Benign tumors are tumors that are not malignant. However, be aware that benign tumors can become malignant. So many times we will remove benign tumors because of the chance of that tumor changing in histology and becoming malignant. So malignant, of course, meaning that they are a cancerous tumor. But those are just some basic definitions with brain tumors. Go back and look at those. When we look at location of tumors, there's an imaginary line that's called the tentorium that we use for the location of brain tumors. So the tentorium is, in this picture to the right, is this red line that you see right there. Essentially what it separates is the cerebellum and the brain stem from the rest of the brain. That imaginary line is how we determine if it is a supratentorial brain tumor or an infratentorial brain tumor. So a brain tumor above that red line or that imaginary line is a supratentorial brain tumor, which is essentially the cerebral hemispheres of the brain. And then the infratentorial brain tumors are the cerebellum, tumors of the cerebellum and the brain stem. We're going to come back to that red line or the tentorium in just a minute because that determines positioning of the patient post-operatively. So that's the biggest thing we're talking about is post-operative positioning when we talk about the tentorium. Lots of different types of brain tumors. We're not going to spend a lot of time on the types, but gliomas being the most common. And the most deadly of those are glioblastomas. Patients that have glioblastomas, usually only about 15% of them survive 18 months. Like we're talking diagnosis and death within a year of with glioblastomas. This video, and I hate that this video has quit working, I'm going to pull another one up, but this video is of basically a research trial where they are using modified polio cells to treat glioblastoma. And Lipscombe is her last name, but I'll see if I can think of her first name. Stephanie is her first name, that's her first name. Alright, so this is Stephanie Lipscombe. She is a survivor of glioblastoma. She was actually in remission. Glioblastoma came back, and she was the first patient they treated with modified polio cells to treat glioblastoma. She was in nursing school when she developed glioblastoma and started her treatment. She is now cancer-free and works at Duke as a nurse in their oncology unit. That's what nursing school did too. It's not going to play. Watch now. Okay, let me try another one. That's Stephanie.
Okay, you've done a great job. The last one's for about 4 minutes and it will be done.
In 2010, Stephanie Lipscombe was diagnosed with glioblastoma, an aggressive type of brain cancer. She underwent surgery to remove the tumor, but it returned 2 years later. She agreed to take part in the first phase of a research trial where a modified poliovirus is injected directly into the tumor. That was in May of 2012. 14 months later, the tumor continues to shrink without the use of chemotherapy or radiation.
The idea of using virus to fight cancer is not new at all. It is at least 100 years old, if not much older. So the tumor, such as Stephanie's, is the worst of the worst of the worst you can imagine. This is a type of cancer that does not respond well to anything out there. So that we are seeing a response at all is remarkable. And then the type of response we have seen with Stephanie is the more astonishing.
So it's not like we took any old virus and used it in this context. This is actually a virus that not only is designed to attack tumor cells because of the specific poliovirus receptor, but it's also a virus that has been genetically engineered to be both toxic to the tumor, but safe to the normal brain and the normal spinal cord. In addition to that, we think that this poliovirus has a very unique relationship with the immune system and is able to stimulate the immune system in multiple different ways, leading perhaps to the immune system coming in secondarily and attacking other tumor cells that may not be killed directly by the virus.
Okay, so we have July 2013, July 2012. So what we can see all over that was area where we knew you had tumor cells. And then here was also the tumor that we treated and how we can barely see anything. A year ago, your brain, today. Good. Okay. I'm really pleased. You're happy too?
Yes, I am.
Congratulations.
Thank you.
You're welcome.
So very satisfying as a scientist to see the predictions made based on laboratory work, to see that in an actual patient. But with this approach, most people's response, and I do understand this, is, are you crazy? Poliovirus? Well, we are throwing everything we got at these tumors. And we have to even get more aggressive on our research effort, because for every patient where we have successes, we have others where we don't. So this spurs us on to work even harder. And there's no time for celebration. It's our job to learn how it works.
Pretty cool. Pretty impressive that somebody even thought of it. But so they are seeing some great results with this modified poliovirus. Like you said, not only is it binding to the tumor receptors and actually killing the tumor cells themselves, but it is causing a secondary a boost in the immune system that is coming in and fighting the tumor also. It's almost like a marker. It basically identifies the tumor for the body, so that the body realizes that it's a foreign object and needs to be attacked. When we, some other types of tumors that we see, meningiomas is another one. The meningioma is typically a benign tumor, and it arises from the covering of the brain. So it's not in the brain tissue, it is on the covering of the brain. The interesting thing about meningiomas, they're usually fairly large, but they tend to reoccur. We do remove meningiomas. They're fairly easy to remove, but it's not uncommon for them to reoccur and the patient have to have that tumor removed again. But they occur in the lining or a covering of the brain, not actually in the brain tissue. When we talk about pituitary tumors, we have patients that typically present with endocrine dysfunction. And so when we say endocrine dysfunction, they are presenting with things like infertility issues, with sleep pattern changes, with hair loss, with fatigue. They present sometimes with very vague symptoms. They can also have SIADH and diabetes insipidus with pituitary tumors. So go back and look at diabetes insipidus and SIADH because we do see that with pituitary tumors. Acoustic neuromas is another one. Acoustic neuromas typically involve cranial nerves specific to the ears. So these patients will many times come in with ringing of the ears, complaining of ringing of the ears. Go back, review your cranial nerves, because we do see acoustic neuromas around cranial nerves. When a patient comes into the ER, and most tumors, by the way, are not diagnosed or found in the ER, but when a patient comes into the ER, it's usually either a severe migraine that they can't get rid of, that they've have been seeking treatment for and have not gotten relief from, or they come in with a new onset of seizures. The patient has a seizure, they've never had a history of seizures, and we scan their head and we find that they have a brain tumor. Most brain tumors are actually diagnosed outside of your ER setting because of headaches. The patient will go in complaining of headaches, or with pituitary tumors, they'll have some endocrine dysfunction. They may be trying to get pregnant, have some fertility issues, and they will find a pituitary tumor. However, many times with these brain tumors, again, they can cause an increase in intracranial pressure. They're just taking up space that doesn't belong to them. And so these patients do have headaches, they have nausea, vomiting, they can have seizures with them. Again, most often CAT scan is how we identify them. Once we have a CAT scan, identify that they have a tumor, then we're going to look at other scans. MRIs to get a more specific look of where the tumor is located. PET scans to see if this tumor is a primary or a secondary tumor. PET scans detect cancer in the body. And so if the patient has a brain tumor, we will scan them and see if they have lesions anywhere else in the body. And then, of course, EEGs, especially if they're having seizure activity, to see if it's affecting the electrical system of the brain. We can treat tumors several different ways. Non-surgically, most often we hear chemo, radiation. Gamma knives is another one that we use to treat brain tumors, and that's what you see to the right here. So the top one's the diagram, bottom one's actual gamma knife, and it uses gamma rays to destroy the tumor. So you have to have several images. You have to have a CAT scan, you have to have MRI, and essentially what they do is they come up with the coordinates for the tumor, kind of like latitude and longitude. There's a specific coordinates for the tumor. And then they take the patient and they put them in this frame, and you can see it kind of in front of his face, but it actually bolts to the skull. So they put some lidocaine at the skin and they screw the bolts to the skull, and they have them in the frame. And then they take the frame and they lock it into the gamma knife itself. Those rays are coming from all different directions of that dome that you see, but they all line up on a single point. Where the rays intersect, we have destruction occur. Doesn't matter what's there. If we lined it up wrong and it was regular brain tissue, normal brain, healthy brain tissue, if the gamma rays intersect, that's where destruction occurs. So we line those gamma rays up to intersect at the point of the tumor. And so the individual rays moving into the skull are harmless, moving through the brain. They cause no damage. At the point that they intersect, damage occurs. It causes destruction, and that's at the point of the tumor. That's why we put these patients in a frame that they can't move. That's why it is bolted to the skull, so that when we lock them into the machine, there is no way for that head to move the intersection point of the gamma rays. We had a student several years ago who had a brain tumor, was actually secondary to testicular cancer. He had testicular cancer and ended up with a brain tumor from it. And he went through gamma knife treatment. And he said, as bad as it sounds, it was actually probably the least traumatic of all of the treatment that he had for cancer. He said, yeah, they put the frame on the skull. He said, but they numb it up, so you don't really feel the bolts at the skull. And he said, you lay there. There's no pain to it. You don't have any side effects from it. He said that was probably the least of all of the treatments that he had, but they used the gamma knife for his brain tumor as well, which is very interesting because we know that there's lots of side effects to radiation chemotherapy. So if we can get rid of some of those side effects and still destroy a tumor, then by far that is a better option. Surgically, when we go into the brain, typically to biopsy, we will biopsy and go ahead and remove the tumor as well. We don't usually just do a biopsy and close up and leave the tumor there. Once we make that incision into the skull and we access the brain, we go ahead and remove everything we can. Many times though with brain tumors, we cannot remove the entire tumor. They'll do what they call debulking a tumor, and when we debulk a tumor, we're getting rid of some of the side effects and some of the symptoms that the patient may have, because that tumor can be very large and can take up quite a bit of space, causing an increase in the intracranial pressure. If we can debulk that tumor, we'll get rid of the seizures, we'll get rid of some of the headaches, we'll get rid of the nausea and vomiting. So if we can't remove the entire tumor, we'll remove as much of it as possible to help alleviate some of the symptoms of the tumor while they're being treated. Postoperatively, remember I told you that the positioning of the patient would have a lot to do with where the tumor was. So if we have a patient that has a supratentorial brain tumor, they will come back in a semi-Fowler's position. Head will be elevated. Why? Because to access a supratentorial brain tumor, the incision point, the entry point into the skull, is at the top of the head. And so when we raise the head of the bed up, what we're doing is we're essentially making sure that the brain is not touching the incision site or the opening of the skull. With an infratentorial tumor, we lay the patient flat and we try to put them on their non-operative side. So with infratentorial tumors, we enter the skull low at the base of the skull, because remember it's the cerebellum or the brain stem that we're accessing. And so we enter the skull low. If we sat the patient up, then the brain would actually be sitting on that surgical area, and we don't want that to occur. So we lay them flat and we try to put them on their non-operative side, so that the operative side is up and we have the brain not sitting on that operative side. So infratentorials, they're flat. Supratentorials, 30 to 45 degrees. Dressings. When we say that we are monitoring dressings, what are we looking for? Do it now? Drainage. What kind of drainage? What kind of drainage is it? Is it massive amounts of blood? Do we have lots of CSF leaking? Or are we having lots of drainage produced? And what did you say, Quan? Bulging. We're looking for bulging at that dressing, because remember, bulging is indicative of an increased intracranial pressure. So there could be something going on. We could have a hematoma that has developed. We could have just manipulation of the brain and a large amount of swelling that's occurring. So we are monitoring for bulging of that dressing. Typically, we do not remove dressings from the head. They are reinforced. Your neurosurgeon or their PA will remove the dressing for the first time. We typically at bedside will only reinforce dressings, neuro dressings, if they've got lots of drainage from them. We're also monitoring labs, because remember, especially those pituitary tumors, but with any of them, they can develop the SIADH or diabetes insipidus. We're looking at urine output, not only urine output, but the specific gravity of the urine that they're putting out. We have to worry about, again, swelling. We have to worry about CSF leaks. Hypertension, intracranial hypertension as well. Again, can all be post-operative complications that we see with with brain tumors. We want to try to prevent these complications, but these are some of those that we do see. Again, the overproduction of CSF fluid, we're not surprised. Remember, anytime the brain is manipulated, the body tries to overproduce CSF fluid. We can see hematomas develop. Again, how do we know if we were having an overproduction of CSF fluid or hematomas develop or an increase in intracranial pressure? What are we going to see in the patient? Before the end, what about level of consciousness? We're going to see a change in the neurostatus of the patient. We're going to see a change in their alertness, how awake they are, what they're following in commands. We're going to see changes neurologically in that neurostatus. That's why they do Q1 hour neurostatus checks on these patients. Meningitis is also a complication, that infection. We're going to talk about meningitis, but not today. And then we can have, again, fluid and electrolyte shifts in the patient as well. The big one with discharge is making sure that we've got them on proper medications, especially seizure medications, to prevent them from having seizures. Anytime we manipulate the brain, we typically put the patients on some type of anticonvulsant. We may wean them off of it 6 months, a year down the road, but initially they all go on an anticonvulsant to prevent seizures. My uncle had a subdural hematoma several years ago. Actually had an evacuation of the subdural, had surgery, was doing great in the hospital. They had him on seizure medication, and there was a failure in communication from the acute care facility to the rehab facility. When he got to the rehab facility, no one continued the anticonvulsant, and he ended up having a grand mal seizure, falling, hitting his head, and having a second bleed because his anticonvulsant did not get continued from the acute care to the rehab facility. So making sure that they have that seizure precaution, it usually takes about a year before we can wean them off of it. My aunt who has had the stroke will always be on Dilantin the rest of her life because she has seizures if she comes off of it. My uncle who has had the head bleed is off of his seizure medication. He's about 3 years out from his head bleed, and he's not on seizure medicines any longer. So it really kind of depends on the patient as to how long they are on that the seizure meds. Some of them will stay on it for life. Others will come off of it, usually within about a year to 18 months. Seizures themselves. So what is a seizure? How many of you have seen a patient have a seizure? Like witnessed a seizure? So what happened the first time you saw a patient seize? Anything?
WTF kind of.
Like, did you just have this sheer panic all of a sudden and felt like you were going to hit the ground for just a minute until you regrouped and said, okay, they're having a seizure?
Down 'cause you just see
It does.
body. Yeah.
It is an overwhelming feeling to watch a patient seize for the first time. It takes you a minute to regroup and go, okay, I can take care of this, because it can be a little scary to begin with. But when we talk about a seizure, we're talking about an abnormal electrical firing of the brain. And so now we can break that down as to, is it all of the brain that we have this, or is it just part of the brain? But when we have this uncontrolled electrical discharge, we can see changes in their level of consciousness, and we see muscle groups affected. We can see them actually have physical movement, motor movement with the seizure as well. If we have a chronic disorder, it is considered epilepsy. But when we look at classes of seizures, so if it is affecting the entire brain, meaning this abnormal electrical firing is affecting the entire brain, it is a generalized seizure. If it is just a part of the brain that is having this abnormal electrical firing, it is a partial seizure. We can break both of those down into further categories. Your partial seizures, you can have simple partial seizures and complex partial seizures. Simple partial seizures, patients typically have an aura. Those are the patients that may taste, feel, see something prior to the seizure itself. Your complex partial seizures, the patients may have a brief loss of consciousness, but they will have a repetitive motion, a repetitive movement. They'll lip smack, they'll pat, they will fidget with a button, but with those complex partial seizures, they do have that, they may have that loss of consciousness, brief loss of consciousness, but a repetitive action. Again, patting, lip smacking, or fidgeting with a button. When we look at our generalized seizures, there's lots of generalized seizures. So a tonic seizure, tonic being a stiffening of the muscle groups. They get very stiff, rigid muscles. Clonic is a rhythmic jerking. So tonic clonic seizures is what we see with our grand mal seizures, is what we typically think of when we think of a seizure. They'll start with a stiffening and they'll move into a rhythmic jerking. When we talk about myoclonic, myo means what? Muscle. So it affects a muscle group, usually in upper extremities or lower extremities. It's usually an extremity group that we see the rhythmic jerking of the patient.
Can you say that again? Tonic was just...
Tonic is a stiffening. Clonic is a rhythmic jerking. Tonic clonic, of course, is the combination, what we see with the grand mal seizures. Myoclonic is typically an extremity group that you see that rhythmic jerking. Absent seizures we see most often in children. With absent seizures, they have a brief loss of consciousness, but it's typically an absent stare that you get. They'll just stare off into space with an absent seizure. An atonic seizure, they have a brief loss of muscle tone, and they may have a head drop. They may be sitting in the chair and their head may drop, and then they'll pick it back up. Or if they're standing, they may collapse. But it's a loss of muscle tone that you see with an atonic seizure. I had a friend that I worked with in the ER, as an adult, had absent seizures. Again, they're most often seen in children, and they have that blank stare. She was pregnant. It was during her pregnancy. She was probably 30 weeks into her pregnancy, and she would come out of patients' rooms saying, I just feel like I can't get anything done. I'm having a hard time concentrating. I feel like I'm just in a fog. I just can't get my head clear. This pregnancy, it must be pregnancy brain. She was just blaming it on the pregnancy. And it went on for weeks, and she finally went and saw somebody. She said, this can't be normal. She started tasting a metallic taste in her mouth. And she's like, this just can't be right. But she was functioning as a nurse in the ER, working 12-hour shifts, but just felt like she could not get a train of thought. She went and saw a doctor. She was having absent seizures. She was having almost 40 seizures a day while she was working. But they were so brief in time that she wasn't noticing that brief loss of consciousness. She was just feeling like she was in a fog all the time. She was always recovering from a seizure. She was constantly seizing. Put her on medicines, cleared up, she delivered and never had another seizure. So something with pregnancy for her, she was having seizures, but working through them. So with these absent seizures, again, they just have that blank stare. They don't lose muscle tone, but it's usually a brief loss of consciousness, and they have that blank stare with them as children. Same thing we just looked at in a diagram, but in a list form. It's there. I'm going to show you a video in just a second, but I want you to flip to this slide, or go to your notes to this slide, where we talk about the care of a patient during a seizure and after a seizure. And we're going to watch this video. There is a lot that goes wrong in this video. There's a little bit that's right, and we're going to talk about what is right and what is wrong in this video. And in that, we will cover the care of the seizure patient. This video is actually released by the facility. The facility was recording it. This is not a reenactment. This is an actual patient video. The patient was going in because her seizures had changed in some way. She was being monitored, so they pulled her off of her seizure medication so that she would seize, so we know what's going on with her seizures. So she is being recorded. She's got electrodes all over her head. She's got room cameras. She's got a sitter in the room during the seizure. And so we're going to look at her seizure and talk about it. Just kind of listen to what's going on in the room, make some notes, and we'll go over it. See if you can identify what's right and wrong.
Okay.
That button she just pressed starts the recording of the EEG. It's not a continuous. It's when she identifies that she's having a seizure.
Okay. You press the button? Okay, the counting nurse.
Can you send the nurse? She's having a seizure.
All right, that is the tonic. You see how she's getting stiff? She's got that, the head's turning. You'll see it in her arms, and her legs will straighten. That's the tonic part of this seizure. She is seizing. All right, she is seizing. Is there anything you would do for her?
Take that pen out of her hand.
Okay, so I would take the pen out of her hand before she starts stabbing herself in the eye. What else?
Move the table.
Move the table away. Those are all constricting things in the environment. What else? Lay her flat. On her side would be even better. What about her glasses? Take them off. All right. What are we going to protect? What do we need to protect? Her head. Her head. All right. So we've identified some of those things. She's moving from tonic. We'll see the clonic part in a second. By the way, she does not breathe during her seizures, so try to hold your breath for this.
She's having a seizure.
Is her head protected? Okay. We're moving into the clonic. See that rhythmic jerking?
The button was pressed.
Watch the color of her face.
2 minutes, the button was pressed right at the time.
Excessive secretion?
She has no suction.
We need to turn her over.
Well, yeah. So how do you turn her over
Okay.
like that? You're going to push her out of the
All right,
bed.
let me explain to you. If I'm seizing and that is what you do to turn me over, we'll come back with conscience. I assure you,
Roll her out of the bed.
this won't be the last time you hear my voice in your head, okay? So, how do we need to turn this patient?
Lay her off.
Okay, so let's lay her down first of all. That would help, right? It's much easier to turn a patient when they're laying flat. What else?
You need to put the rails up at least or something.
Well, the rails are up. They're up.
The rails are up.
Move the pillows. So let's roll her and put her face in the pillows. By the way, she's not breathing and let's assure that the first breath that she tries to take is in a pillow. All right? So let's remove her pillows. Let's truly lay her down and move her over. That is what my daddy would call half-ass. That is not rolling a patient. That is saying you're going to roll a patient and not doing it. Which, it gets even better. It gets better. Really? You can't make this stuff up.
How is this on YouTube?
The hospital released it to the patient and the patient put it up.
I would have been
not knowing any better. Remember, we're talking about lay population that doesn't know anything about healthcare. All right, that was her first attempt at a breath. That is what you hear is snoring respiration. Conversation gets interesting. That is an ineffective respiratory pattern. That is not effective.
I can get our suction set up, please. It's supposed to be set up.
Why didn't they set it up before?
It's supposed to be set up. Is she moving air? No.
Oh, look at her breathing just fine.
That sounds so awful, y'all.
It is awful. If you checked her stat right now, she's probably in the 60s. So we're going to set her up and put a pillow behind her head. What just happened to her head?
It just closed her airway.
It was closed in airway. All right, good Lord steps in. Thank God. And this woman wakes up enough to control an airway and takes the first breath. And we are
3 minutes.
3 minutes and 55 seconds into this video. So now what is happening to the metabolism of the cells in the brain at 30 seconds?
In overdrive.
It is altered.
Because
2 minutes, we see metabolism slow and death occur at 5. So every time this woman is having a seizure, we are seeing a change in the metabolism of the cells of the brain. So what are we seeing long term?
they're dying. The brain cells.
Absolutely. Long term, we are seeing anoxia occurring in this patient because of seizures. That is probably why she is here, because we need a better control of her seizure medication. All right, so what we've been hearing up to this point was what they call a snoring respiration. It is not an effective respiratory pattern. So essentially, the soft palate has dropped and is occluding an airway. That is an upper airway occlusion. If you hear a patient snoring, just like my husband at night, if he's not wearing his CPAP, he snores. It is an upper airway occlusion. What do we do to fix those? We don't leave them, by the way. We don't let them just snore. What do? We reposition them, right? Like at home, I can elbow him and tell him to roll over, and he'll roll to his side, and guess what? The snoring stops. It's the same thing here. Her airway has occluded. She has an upper airway obstruction, so she has a respiratory drive. Her body is trying to breathe, but there is a occlusion in the upper airway, so you get that snoring. We could reposition her. We could lay her on her side. We could tilt her head back and open that airway. It could be that simple, and she would start breathing. At this point, we all agreed that there should be suction set up, right? When should suction have been set up? Before the patient got in the room. What are seizure precautions? Is suction set up on there? Absolutely. Absolutely. Court of law. Unfortunately, Miss Hamilton dies today during this video, and now her family is going to sue because she has died from a seizure. Court of law, they are watching this video because the hospital released it to the patient. They're watching this video. Who is held liable for not having suction set up?
The nurse.
The nurse that is at bedside. The nurse that is there now. What if she wasn't admitted on this nurse's watch? What if she was admitted yesterday?
Still her responsibility.
It is still her responsibility.
She's been caring for the patient and she's the one who's there.
That's
If
right.
you knew you were going to take her off of
That's right.
medication, you should have already had that and a Dynamap and everything to record the same.
The fact is she's under this nurse's care at this moment in time. It is that nurse's responsibility. And so this is going to lead into one of my pet peeves. As a house supervisor, we implemented in all of our facilities years ago bedside shift report. Why? Was it because we really wanted you to talk in front of the patient and they're an active member of their healthcare team and they get to make decisions? Yes, we want them to have their say-so in whatever we do for them. But why do you think we really implemented bedside shift report?
Another nurse can get anything in
For safety, exactly. Safety of the patient. So Jay and I are walking into this room, and I've had Miss Hamilton all night long, and I am now standing in the bedside, and I'm introducing Miss Hamilton to Jay, and I said, hey, Jay, or Miss Hamilton, this is Jay, and he's going to be taking care of you today. And while I'm talking and telling Jay about Miss Hamilton, what is Jay doing? He is assessing. We assess visually. We scan the room. And Jay says, uh-oh, there's no suction setup. Let me send the tech, the monitor, whoever's in the room, to go get suction set up. And before I leave the room, guess what Jay's now got covered? Suction. It is there. So now if Miss Hamilton seizes and Jay is in the room, guess what he has covering him? Seizure precautions with suction setup. Now, when we go to the court of law, guess who's going to back Jay in court because he had his suction set up? The hospital. Now he has covered, his facility is going to back him because he has followed their seizure precaution protocols, and it says suction setup. That hospital will back him. What if it were me and Miss Hamilton died on my shift and I didn't have suction setup? Is my facility going to back me? No. Why? Because I did not follow policy. And because I broke policy, my facility is not going to stand there in the court of law with me. I am on my own. Remember, we just had a nurse that was tried and convicted and will serve time because of a medication error. Our livelihoods are in jeopardy. Our caring for patients, our license are on the line each and every day that we take care of patients and we don't follow hospital policy. So that's why we do bedside shift report. It's not because we want every nurse to make sure that they have walked in every room during their shift. We do it for patient safety so that things like suction are caught at bedside shift report. Jay's coming on to his shift. He's not 12 hours into it. He is fresh. He's going to pick up on it much sooner than I am 12 hours into the shift coming off shift. That she needs suction set up in the room. All right, we also identified that she needs her head protected. Now, did they attempt to do that with the bed sheets or the blankets? They did. They wrapped the rails, and that is acceptable. However, that bed's been in a semi-Fowler's, high Fowler's position for 6, 8, 12 hours, and the sheets have slid down the rail. So now is her head protected? No, it's not. Why don't we take the pillows that we're putting behind her head out from behind her head and shove them down between her bed rail and her mattress? That will now protect her head. So this conversation goes on about suction setup. Miss Hamilton's going to breathe for us. Do we need an oxygen saturation on Miss Hamilton at this point?
Yeah.
Why? She's breathing.
Feel to see where she's at. See how far she goes.
Does it matter? What are we going to do different now that we would have done without checking it? Does this patient need oxygen? Yes? She does. It doesn't matter what her stat is. She needs oxygen. She ain't been breathing for the last 3 minutes. She needs oxygen. So does it really matter what her stat is at this point? She's post-ictal.
Yeah.
She is breathing. Does Miss Hamilton have a clue as to where she is?
Okay.
Nope. And by the way, are you okay? Is that therapeutic communication? No. I hope 201 comes back and haunts you if you ask the patient if they are okay. The answer is hell no, they're not okay. They just had a seizure. They don't know where they are or who they are. They're not okay. So what are we going to do? What do you say to Miss Hamilton at this point?
Do you know where the whole?
No. Do we want to know if she knows where she is? No, we orient her. We're going to say, first of all, we're going to call her by name. Miss Hamilton, you have had a seizure. You're at the hospital, and we are going to take good care of you. That is it. Do we care if she knows her birthday or who the president is? No, we don't. All we want her to do is relax. She is post-ictal. We need a nice, calm, quiet environment during this post-ictal phase. We don't need beeping of sat monitors. We don't need bed rails going off. We don't need call lights. We don't need the desk calling into the room. We don't need bright lights. We need all of this to be brought down and very nice, calm, and quiet. I tell people all the time that Miss Hardwick, or Dr. Hardwick, is who they need at bedside during a post-ictal phase. Not me. I am not your therapeutic post-ictal phase nurse. And we all have our place in nursing, but that would be Dr. Hardwick, not me. She would definitely be that nice, calm, soothing, therapeutic, very quiet nurse that you want at bedside. Not that the bull in the china shop. I can take care of you in an emergency, but that's not it right there, okay? So we need to think about quieting the environment down. So let's listen to the environment. She, by the way, has no clue as to where she is.
You okay?
People start talking in bed rails.
No, what are you doing?
So what is she going to do?
Trying to get away.
She's going to try to get away. Remember we have...
No.
Miss Hamilton?
No.
First time somebody calls her by name. Remember we have that nice sympathetic nervous system response, fight or flight. She has no clue as to what's going on. She's going to do one of two things. And she is going to flight. She's going to leave. I don't blame her. Because she's looking at somebody and hearing the call light come in on a bed rail, and the face and the voices aren't matching. That sympathetic nervous system's going to kick in. Now, when they tell her to get back in bed, she follows directions, but she didn't have a clue as to what's going on.
I would say it lasted good evening.
So, what that we could change about this video, and I think we've talked about most of them, from positioning to getting her flat to making sure, oh, by the way, nothing in their mouth. We used to put bite blocks in. We don't put bite blocks in. Nothing goes in the mouth of a patient that is seizing. Not even suction. Now, postictally, we can suction them, but not while they're seizing. While they're seizing, if they have all these excess secretions, what can we do? All we can do is roll them to their side. Give those secretions a way to leave the oral cavity, but we cannot suction during the seizure. So we do want to provide privacy if possible. If we are up walking the patient, then we put them on the floor. Do we grab her by the arm and say, hold on, Miss Hamilton, we got to get back to your room, and we run back to the room before she seizes? No. Wherever we are, we stop and we put them on the floor. If we're putting them on the floor, of course, we want to close rooms around us. We want to put a sheet over. We want whatever we want to do to provide some privacy for Miss Hamilton. She starts seizing. What are we going to protect? Her head. How are we going to do that?
Put a pillow or...
Pillows sometimes. Can we put our hands under their heads?
Yes.
Yeah, you can, but you're going to have broke hands when you get done. Because what's going to happen is you have this hard floor and their skull banging on your head, and you're going to have that occurring to your hands while they're seizing. So what you really want to do is, and I practice hard, I make sure I have these nice thick thighs right here, and you sit down Indian style and you put their head in your lap. I mean, anytime anybody seizes, I got your head protected. I work hard at it, okay? So use what you have. Use your thighs to make sure that they have that head's protected. Well, what about their heels and elbows and wrists? Are we going to be able to protect them? No. Nope. They may have a skin tear, but guess what? You just chart it. You know that they have a skin tear. And what you do about it. All you're going to do is treat it, right? You're going to put some ointment on it. You're going to cover it. And you're going to do dressing changes on that skin tear. We can't protect their entire body if they're up, but we can protect their head. Patients that are on seizure precautions can get out of bed. Remember that. They just have to have assistance getting out of bed. There has to be somebody with them when they're out of bed, but it doesn't mean that they can't get out of bed. We move things out of their hands. We remove the hospital table tray from in front of them. We get pencils out. We remove glasses. Do we reach in their mouth and take out their dentures?
No.
No, they'll bite your finger off. No, we want those dentures out before they seize. But we do open an airway. Can we, while they're seizing, do a head tilt, chin lift on them to open an airway?
No.
No, we cannot. We can injure their neck doing that. All we can do is roll them to their side, and then when they're in that postictal phase, we can tilt that head back to make sure that they don't have that upper airway obstruction. Questions about how we care for the patient during or after the seizure? All right, and we are going to stop there. We will pick up on meningitis on Thursday. I should see everybody in simulation this afternoon.